Histologically, sites of infection are involved by a characteristic inflammatory reaction, marked by the presence of caseating and non-caseating granulomas, which consist of epithelioid histiocytes and multinucleated giant cells. Let's view the morphologic spectrum of tuberculosis. Figure A shows the characteristic tubercle at a low magnification, while Figure B shows a higher magnification for the same focus. As you see, the black arrow points to central granular caseation, surrounded by epithelioid and multinucleated giant cells highlighted by the yellow stars. This is the usual response in individuals who develop cell-mediated immunity to the organism. Occasionally, even in immunocompetent patients, TB granulomas may not show central caseation as in Figure B. However, irrespective of the presence or absence of caseous necrosis, special stains for acid-fast organisms are always indicated. Figure D shows acid-fast stain decorating sheets of macrophages packed with mycobacteria. This specimen is from an immunocompromised patient. Secondary tuberculosis arises in a previously sensitized host mostly many decades after initial infection. When host resistance is weakened, it also may result from reinfection. Only a few patients with a primary disease subsequently develop secondary tuberculosis. Secondary pulmonary tuberculosis is classically localized to the apex of one or both upper lobes. Because of the pre-existence of hypersensitivity, a marked tissue response follows immediately and tends to wall off the focus. This localization results in less involvement of regional lymph nodes, especially if compared with the primary tuberculosis. On the other hand, cavitation occurs readily in the secondary form, leading to erosions and dissemination along the airways. Such changes become an important source of infectivity because the patient now produces sputum containing bacilli. The initial lesion usually is a small focus of consolidation less than 2 cm in diameter within 1 to 2 cm of the apical pleura. The foci are sharply circumscribed, firm, gray-white to yellow areas that have a variable amount of central caseation and peripheral fibrosis. Histologically, the active lesions show characteristic coalescent tubercles with central caseation. The tubercle bacilli can be demonstrated by appropriate methods in early exudative and caseous phases of granuloma formation. However, it's usually impossible to find them in the late fibrocalcific stages. Localized apical secondary pulmonary tuberculosis may heal with fibrosis, either spontaneously or after therapy. Otherwise, the disease may progress and extend along several different pathways. In progressive pulmonary tuberculosis, the apical lesion enlarges and the area of caseation expands. Erosion into bronchus evacuates the caseous center, creating a ragged irregular cavity lined by caseous material that is poorly walled off by fibrous tissue. Erosion of blood vessels results in hemoptysis. With adequate treatment, the process may be arrested, although healing by fibrosis often results in distortion of the pulmonary architecture. If the treatment is inadequate or host defenses are impaired, the infection may spread by direct extension and by dissemination through airways, lymphatic channels, and vascular system. This figure shows involvement of upper parts of both lungs by gray-white areas of caseation and multiple areas of softening and cavitation in a patient with secondary pulmonary tuberculosis. Miliary pulmonary disease occurs when organisms reach the bloodstream through lymphatic vessels and then recirculate to the lung via the pulmonary arteries. The lesions are small with foci of yellow-white consolidation scattered through the lung parenchyma. It's called miliary due to the resemblance of these foci to the millet seeds. With a progressive pulmonary tuberculosis, the pleural cavity is invariably involved and shows pleural effusions, tuberculous empyema, or obliterative fibrous pleuritis. Endobronchial, endotracheal, and laryngeal tuberculosis may develop when the infective material is spread either through the lymphatic channels or from the expectorated infectious material. The mucosal lining may show minute granulomatous lesions that can be seen only sometimes under the microscope. Systemic miliary tuberculosis happens when the organisms disseminate hematogenously throughout the body. It's most prominent in the liver, bone marrow, spleen, adrenal glands, meninges, kidneys, fallopian tubes, and epididymis. This figure shows miliary tuberculosis of the spleen. The cut surface shows numerous gray-white granulomas. Isolated organ tuberculosis may appear in any organ or tissue, seeded hematogeneously, or may be the presenting manifestation of tuberculosis. Organs typically involved include meninges, kidneys, adrenal glands, bone, and fallopian tubes. When the vertebrae are affected, the condition is referred to as pot disease. Lymphadenitis is the most frequent form of extrapulmonary tuberculosis, usually involving the cervical region. Lymphadenopathy tends to be unifocal, and most patients do not have a concurrent extranodal disease. HIV positive patients almost always have multifocal disease, systemic symptoms, and either pulmonary or other organ involvement by active tuberculosis. Clinically, the disease can be asymptomatic, especially in localized secondary tuberculosis. When manifestations appear, they are usually gradual with development of both systemic and localizing signs and symptoms. Systemic manifestations are related to the release of cytokines by activated macrophages, mainly tumor necrotic factor and interleukin 1. This often appears early in the disease course and include anorexia, weight loss, and fever. The fever commonly is a low grade appearing late each afternoon and then subsides. Night sweats may occur too. With progressive pulmonary involvement, sputum increases and it's mucoid at first and purulent later. When cavitation is present, the sputum contains tubercle bacilli. Some degree of hemoptysis is present in about half of all cases of pulmonary tuberculosis. Pleuritic pain may result from the extension of the infection to the pleural surfaces. Extrapulmonary manifestations of tuberculosis depends on the organ system involved. So if it involves the fallopian tubes, this may present as infertility. Involvement of the meninges may present with headache and neurologic deficits. Pot disease may present with back pain and paraplegia. The diagnosis of pulmonary disease is based on history, physical, and radiographic findings of consolidation or cavitation in the apices of the lungs. Ultimately, tubercle bacilli must be identified by one of the following methods: demonstration of acid-fast organisms in the sputum, and this can be by staining or by the use of the fluorescence auramine, rhodamine, and this is considered the most common methodology for diagnosis of tuberculosis. Conventional cultures for mycobacteria can be used too, however, it requires up to 10 weeks. Liquid media based radiometric assays, on the other hand, are able to provide an answer within 2 weeks. PCR amplification can be performed either on a liquid media with growth or with tissue sections. However, culture remains the standard diagnostic modality because it can identify the occasional PCR negative cases and also allows testing for drug susceptibility. The prognosis is determined by the extent of infection, localized or widespread, the immune status of the host, and the antibiotic sensitivity of the organism. Now let's try to solve this case. This is a case of a 45-year-old lady who has a routine health maintenance examination. On physical examination, there are no remarkable findings. Her body mass index is 22. She does not smoke. A tuberculin skin test is positive. A chest radiograph shows a solitary 3 cm left upper lobe mass without calcification. The mass is removed at thoracotomy by wedge resection. The microscopic appearance of this lesion is shown in the figure at the left. Which of the following is the most likely diagnosis? Mycobacterium tuberculosis infection, necrotizing granulomatous vasculitis, poorly differentiated adenocarcinoma, Staphylococcus aureus abscess, thromboembolism with infarction. This figure represents the histologic findings of the mass. So what are the clues in this case? The clues in this case include the following. First, a positive tuberculin skin test. Then, the radiographic findings, and most importantly, the histologic picture. This figure shows a pink amorphous tissue at the lower left, representing caseous necrosis. The rim of the granuloma has epithelioid cells and Langerhans giant cells. So we have caseating granulomatous inflammation. Caseating granulomatous inflammation is most typical for Mycobacterium tuberculosis infection. In the history, they mentioned that there were no calcifications. Calcification would have helped to identify the mass as an old granuloma, not likely to be a neoplasm. So the diagnosis for this case is Mycobacterium tuberculosis infection. For your questions, please contact me at my email, Microsoft Teams, or e-learning website.